Thank you for joining the One Lambda webinar today. My name is Michelle Zubricki, post-transplant medical science liaison with One Lambda. We have an exciting presentation today in store for you, Molecular Diagnostics, Getting There. Dr. Gaurav Gupta is our esteemed speaker. He's an associate professor of medicine and surgery at Virginia Commonwealth University. Dr. Gupta is the medical director of the Kidney Pancreas Transplantation Program, as well as the vice chair of the Division of Nephrology. Dr. Gupta is regarded as an international expert on the use of molecular diagnostics in kidney transplantation. This presentation will be recorded for future viewing through the One Lambda website. Please type any questions that you have in the Q&A box at the bottom of the screen. Questions will also be answered at the end of the presentation. It's now my pleasure to turn the program over to Dr. Gaurav Gupta.
Good evening or good morning, wherever you may be. So I'm going to share some newer data about the molecular microscope today, as well as about the background as to how it's being used in kidney transplants. Our hope for the future is that we can integrate these molecular diagnostic tests into regular practice moving forward. These are my disclosures. So as is well known, probably to most of the audience, we've known for the last several years that conventional diagnostic systems like histology may have some inherent noise to them. And the reason for that may be because of some poor inter-observer agreements, as well as algorithms which may evolve over time and therefore are not as reliable when interpreted in the future. So with regards to histology, what is well known is that normal versus abnormal is fairly easy to appreciate, but once you hit the abnormal diagnosis, the ability to distinguish different kinds of pathologies, for example, rejection, may not be as good between observers. To give an example, for T-cell mediated rejection for kidney transplants, the agreement between two observers is no higher than 50%, and this drops much lower for other organs like the heart and the lung. So the important point to appreciate for this topic is that when we start looking at new tests, which try to do better, so to speak, the degree to which a new system like a molecular microscope agrees with the conventional system, like histology, will be limited by the noise in the conventional system. And therefore, we cannot expect 100% agreement between these modalities of diagnosis. So what are the sources of errors in histologic biopsy interpretation? One may be sampling errors. That a single small sample may not represent the entire organ. There may be issues with the location of the organ that is biopsied. For example, the medulla may not be as reliable compared to the renal cortex for the diagnosis of rejection. There may be problems with the lesions being non-specific. For example, V lesions may indicate both antibody-mediated rejection as well as T-cell mediated rejection in the correct context. And then finally, assigning categories with regards to boundary error. For example, if you have 4 lymphocytes in a tubule, that becomes T1, but 5 becomes T2. And this can create inherent problems because biology is not really a dichotomous variable. So can we use machines to derive a better system which is less prone to individual errors? And MMDx is one such system which aims to do that. And the way it does that is by using a central diagnostic system that uses gene expression by microarrays to measure transcript changes in biopsies compared to a reference set. A large number of genes is analyzed at the same time, and then it's put through an algorithm to identify different states which are defined here. For example, for rejection, it may be T-cell mediated rejection and antibody rejection, but within ABMR, there may be further substaging of early stage, fully developed, or late stage. And then beyond that, there are injury states, which represent a response to wounding, which can include acute kidney injury, atrophy scarring, as well as a possible ability to predict risk of progression to failure. So this is the usual algorithm for how biopsies are processed. The short version of this is that once a biopsy is collected at the clinical site, it's shipped overnight to the central site, which at the current time is the Kashi lab in Oregon. And then beyond that, further analysis is done, resulting in a report generation. And the usual time frame for this is around 24 to 36 hours from the time the tissue is received at the central location. So this is what the biopsy looks like. At the top is the patient information and clinical information, which is provided by the clinicians who send the biopsy. This is what the visualization of the report looks like, and I'll talk about that in more detail in the next slide. This is a summary of molecular changes, which are essentially quantitative scores which define each of these states, which I described to you in the last slide, with regards to rejection, acute kidney injury, atrophy fibrosis, as well as TCMR and ABMR. These are further details about archetypes of rejection, which once again I'll describe to you in the next few slides. This is additional detail which compares the current biopsy, the index biopsy, to what may be considered normal from the reference set. There's a very interesting adherence index, which is also reported in these biopsy reports, which is derived from the reference set, and it measures molecular hyalinosis, or AH. In our hands, it's been a very interesting test to look at because it determines that because of a low AH score, a patient may have been not yet adherent, and that may be driving their clinical state of rejection. This is an analysis of what the nearest neighbors of that particular biopsy have looked like in the past based from the reference set. And this is another interesting point, which is about the survival of other kidneys like this one with regards to prediction for the future. And this can be important for the clinician because it helps us understand how aggressive we need to be with regards to therapy. And then finally, there's a clinical interpretation, which is provided at the current time by Dr. Halloran, but it can be machine read also. So again, as many of you may know, the MMDx project has been ongoing for several years now. And at this point, there are more than 4,500 organ biopsies in this cohort. Around 2,000 of those are kidney biopsies. So these are the molecular archetypes of rejection, which can be machine read. And to give you an example, the commonest way a biopsy may be read as no rejection would be as in the no rejection arm, which is A1. You may have A2, which is T-cell mediated rejection with the red dots. With A3, it's severe TCMR or mixed rejection, which can be seen in non-adherent patients. And then there are three categories of ABMR, which can be early stage, late stage, and fully developed. When you flip this view by 180 degrees, you start seeing that the ABMR cohorts start separating out from each other, as you can see now, into three different cohorts, which is more visible. And this is a PC2 view compared to PC1. And then a new biopsy, which is sent by the clinician, is then projected into the space, and then the report is generated, which I just showed you in the last slide. So the relevance of these different disease states is shown in this next slide, where you can see that the time points where each of these diagnoses can be found is variable. To give an example, early ABMR is early on in the first 1,000 days of transplant, and then it wanes off compared to fully developed or late ABMR, which starts spiking after several years of transplant. And the second relevance of this is because of prognoses. As you can see, fully developed ABMR and late ABMR in the purple and blue have the worst prognosis compared to other disease states. And once again, the relevance of this is that if one sees these reports with these particular diagnoses, it can help the clinician decide about how aggressive one needs to be with regards to management. So we've been using MMDx for the last almost 7 or 8 years now, initially as part of the INTERCOMEX extension study, and then subsequently as clinical studies. Now, at the current time, we have almost 600 biopsies in the clinical cohort. But this is the data analysis, which I'll show you, of the total of 600 some biopsies in these two cohorts. So this is our workflow for reference. We typically take 2 cores of kidney transplant biopsy tissue. We use 16 gauge needles in the biopsy suite. All of the biopsies are done by the nephrologist. We divide one of those 2 cores, and then a fourth or a third is then suspended immediately in RNA in the biopsy suite. In the research study, these used to be FedExed overnight to Edmonton, but now we send them to the Kashi lab in Oregon. These samples are shipped on room temperature. They do not degrade that easily when you suspend this in RNA. But the key point, unfortunately, is that the biopsy has to be a frozen, a stat fresh specimen, as opposed to frozen or formalin or paraffin embedded. MMDx results are typically interpreted on day 2 post-biopsy. And then once we look at the entirety of the clinical data, we then decide whether management decisions need to be altered based upon what we know from all of these clinical parameters. So just kind of a snapshot of what we've seen with when we look at comparisons of MMDx and histology. Overall, there's a fair degree of agreement between these parameters. For example, if you look at the ABMR score of MMDx on the y-axis, and microvascular information as measured by PTCNG on the x-axis, you see a nice correlation, which is graded. A similar correlation is seen between atrophy fibrosis on MMDx versus IFTA, or interstitial fibrosis and tubular atrophy on histology. You see a much less tighter correlation between INT, which is interstitial inflammation and tubulitis, compared to TCMR scores on MMDx. And that's not a new finding anymore. And I'll discuss this in a lot more detail with regards to management in the next several slides. There's also a global disturbance score, which essentially is a marker of overall inflammation, as well as an acute kidney injury score, which is provided in the report. And we found that the severity of AKI on the molecules is very strongly correlated to the severity of acute kidney injury as measured by kidney function, or GFR. And this is the AKI score correlation, and you see the same for global disturbance. This is not a novel finding. It's been reported as far back as 2012 by Dr. Halloran's group. The relevance of this will become clear later on at the end of the talk because it associates with outcomes as well as some newer diagnostic tests which are coming out now. So in the initial 600 biopsy cohort, we looked at the discrepant cases where MMDx diagnosis was different versus histology with regards to rejection. So of those cases, around 51% had their diagnosis downgraded by MMDx, and around 37% had their diagnosis upgraded by MMDx. When we look at the cases where the diagnosis was downgraded, we see that nearly half of those cases had T-cell mediated rejection on histology, but not so on MMDx. Around a third or so had antibody-mediated rejection on histology, but not so by MMDx. So this, again, as you can imagine, has pretty significant management implications for the patient. What about upgrading of diagnosis? So in nearly 2/3 of the cases, all of these upgrades are associated with antibody rejection, which means that MMDx picks up ABMR, while histology says that there is no rejection in these cases. In around a fourth of these cases, MMDx picks up TCMR, but there is no rejection on histology. And most of these cases are either BK virus or acute pyelonephritis because of bacterial infections. Now, this is nuanced, and I'll talk about the BK virus story in the next few slides, because it's not as simple as saying that MMDx is false positive for TCMR. It may be that many of these cases have coexistent rejection and BK virus nephropathy. A common question which comes up is, what about the misdiagnoses by MMDx? And as you can see, most of these are glomerular diseases. And therefore, I always say that MMDx and histology are essentially techniques which complement each other. Because if you want to look for a lot of glomerular pathology, that cannot be done by whole gene expression from the tissue. For example, here you can see a large number of patients with MMDx negative biopsies within quotes for rejection turned out to have FSGS or other glomerular diseases. So in the INTERCOMEX extension study, when we asked clinicians about the agreement of MMDx with clinical diagnosis, around 70% of the time, the clinician agreed with both MMDx and histology diagnosis. Around 20% of the time, the clinician agreed with MMDx, but not with histology. And then that brings out to a total of 30% disagreement with histology overall in this paper. So what do these disagreements mean? This was further analyzed in a follow-up paper published a couple of years ago, which is listed here, where if you look at these discrepant biopsies, around 40% of the time, MMDx called it ABMR, but histology did not. And that remains a common theme from our own in-center, single-center data from before. Around 15% of the time, MMDx called TCMR, but rejection was not called by histology. And around 10% of the time, histology called TCMR, but no rejection by MMDx. So essentially, once again, these techniques should be complementary, and the clinician needs to consider these data together as opposed to taking one or the other as the source of complete truth. So I'll talk about a few case vignettes from our center. This was one of the earliest cases which we had in MMDx. This was a 43-year-old male who received a kidney transplant 1 year ago. He was not sensitized at the time of transplant. He presented 1 year after transplant with a rising creatinine and proteinuria. His initial kidney biopsy did not demonstrate rejection on histology, although MMDx on the same biopsy was read as active antibody rejection. As you may have heard me say before, this was one of our very early cases. Therefore, we proceeded to do a second biopsy for this patient. And on this biopsy, we did find findings concerning for antibody-mediated rejection, even on histology. So the idea here is that the initial histologic test may have been false negative, and that's known because tissue diagnosis be focal in origin. The second case demonstrates a response to therapy impact of MMDx, and this was a lady who was sensitized because of prior pregnancies. She got a first transplant in 2018. Her time of transplant cross-match was slightly positive. She also had class 1 donor-specific antibody. As per our protocol, she got a surveillance biopsy at 1 month post-transplant, which showed acute antibody-mediated rejection, which was positive both by histology as well as MMDx. She received therapy as per our center of care with plasmapheresis, and then a follow-up biopsy was once again performed as per our SOC. Histology once again called it ongoing antibody-mediated rejection, which is seen in these pictures with the glomerulitis and the peritubercular capillaritis. On the other hand, MMDx showed no ABMR or TCMR. So because of this resolution of DSA as well as a negative MMDx, we chose not to treat this patient further. And with that, she got 2 other surveillance biopsies, which were both negative even by histology. And this patient is now, at this point, almost 5 or 6 years post-transplant with excellent kidney function. So these vignettes offer you a snapshot of how complementing MMDx can help you with avoiding overtreatment, as well as picking up rejection before, which was false negative, possibly on histology. So how does it play out with regards to costs? So this paper was published in the last 2 months, and what it looks at is a cost comparison of using histopathology alone versus histopathology plus molecular microscope for treating rejection. And again, this is a complicated schematic, which I don't need to go through in detail for the interest of time. But if you have questions about this, I would be happy to answer offline or at the end of this discussion. The point is, the intent of this analysis is to look at whether adding MMDx histology may result in added cost versus reduced cost with regards to graft failure, functioning graft, as well as patient mortality. So we used these percentage distributions of diagnosis to compare these different disease states. And this is derived from the publication which I showed you earlier with regards to the percentages of each diagnosis. What this table shows you at the bottom is that when you incorporate MMDx in the center of care for ABMR, there is a resultant net loss of around $1,300 because more cases of ABMR are picked up by MMDx than for histology. On the other hand, one saves a few dollars, $80 or so, by incorporating MMDx into TCMR diagnosis, as a few cases are no longer identified as TCMR by MMDx. Either way, the net impact of this whole analysis is an addition of around $1,100 or so of rejection therapy per biopsy in these cases. So how does this translate into graft loss versus graft failure reduction? And this graph shows that. So when you look at the break-even analysis for MMDx of graft failure from rejection, there needs to be just a 5% reduction in graft failure, as you can see here in the orange line, to offset the increased costs associated with MMDx incorporation of practice. The blue line represents a savings per test and increasing percentages of reduction in graft failure from rejection with MMDx. So I'm going to move on to the next case, which describes a disagreement with histology in this case. And this was a 41-year-old female who got a second kidney transplant. Her first transplant had failed due to BK virus nephropathy. Over the first 4 months of transplant, she had a rise in creatinine from 1.4 to 1.8, and a kidney biopsy was read as severe T-cell beta rejection. On the other hand, the MMDx showed low probability of either ABMR or TCMR. But when you look at the histology of this kidney, it is grossly inflamed. You can see severe inflammation, which is essentially completely involving the tubules in the incision. So for this lady, her BK virus PCR in the blood was negative at the time of this biopsy. But given the context of this biopsy and MMDx being negative for TCMR, we sent off repeat PCRs in-house as well as to an outside lab. And as it turned out, her urine BK PCR was positive at our own lab, and the plasma BK PCR came back positive as an outside lab. So when we repeated the test in our lab with the different primer and probe set for BK, it also turned positive. And the context of this case is that we know that BK virus can mutate over time, and therefore it may not be picked up by different assays. So The context of this case would be that in the correct clinical setting, one needs to think outside the box to ensure that the correct diagnosis is obtained for a specific patient. Now, again, I'm sure many of the audience knows that BK virus nephritis is a difficult problem, and patients with BKVN may have coexistent rejection, commonly TCMR, but sometimes antibody-mediated rejection also. So in this study, we look at the expression of BK virus RNA in the kidney tissue. And these are historically stored samples from the INTERCOMEX extension study. And these were all biopsies which had a proven histologic diagnosis of BK virus nephropathy. So what you can see here is that molecularly, these patients can have a spectrum of diagnoses that includes pure BKV nephritis on the left, BKV with TCMR on molecules in the middle, BKV with molecular ABMR in the middle, pure histologic and molecular TCMR with no BK in the tissue by RNA, and then finally no rejection and no BK nephropathy in the tissue. So the intent of this slide is to show that it is possible in the future that we can actually start looking at BK virus in the tissue by PCRs, and that may help us differentiate BK virus nephropathy as an isolated disease to a continuum where now BK has evolved into a T-cell mediated rejection process or an antibody rejection process. And that may help us in identifying when to increase immunosuppression in a patient where BK is getting better, and now they're moving towards autoimmune rejection instead. So the last vignette for this presentation was a 71-year-old man who got a kidney transplant in 2019. He did have some low-level donor-specific antibody. He had some early delayed graft function from which he recovered, but then he had viral pneumonitis, which required an ICU stay. In that setting, his immunosuppression was temporarily held and then resumed at a low dose. He gets admitted at around the 2-month mark with acute kidney injury. He also had some GI symptoms. This is his creatinine. You can see that it gets better, but then over time with the admission, it goes up. In the context of DSA, we performed a biopsy on him, which was read as borderline TCMR by histology, but on the MMDx, it was read as relatively normal kidney transplant biopsy. And you can see with the yellow triangle that this patient is very much in the black category of this slide, which is consistent with no rejection. So given the clinical context of somebody who has GI illness, we assume that his AKI was because of that as opposed to rejection, and he was not treated with any specific therapy. And you can see this is what happens to his kidney function here. Without any specific therapy for rejection, his creatinine improves and goes down to a very nice level, even below his initial baseline. So we've now taken this TCMR experience to the next level, where I'm showing you further data on how we use molecular tissue gene expression to guide therapy for TCMR. So in this study, we divided patients into 3 categories: those with both histologic and molecular rejection, or H plus M plus; those with histologic but no molecular rejection, or H plus M minus; and those without rejection by both techniques. And these are all biopsies done in the same era, between 2017 and 2020. So you can see that H plus M minus has a lot more borderline and early rejection versus a higher grade of rejection for H plus M plus. But the key point of this trial is that we did not intensify immunosuppression with regards to highest dose steroids or thymoglobulin for patients with H plus M minus category of rejection. When you look at the histologic grades of severity of the lesions for these 3 groups, what you can see here is that there is a milder I and T in H plus M minus compared with H plus M plus, but nevertheless, it is worse than H minus M minus, meaning they do have inflammation, but they do not have rejection based upon the molecular tools. The big question here is whether this represents TCMR. And in theory, of course, the key is that in case this does represent TCMR, these patients would develop worsening kidney function over time. So when you look at the molecular scores for TCMR here, you see a pretty significant difference where H plus M minus on the extreme left has almost no TCMR on the gene expression compared to the H plus M plus group. Similarly, what you do see is that both global disturbance and AKI scores are worse for H plus M plus, but they are detectable for H plus M minus and worse than the no rejection group. So renal function as measured by GFR was measured here on this slide, and this is GFR at biopsy, at the index biopsy on the left, and then over time, over the next 12 months of follow-up after the initial biopsy. And what you see is the GFR was worse at the time of biopsy in the H plus M plus group, which is the green line, the dotted green line, and the average was around 35 there. When you compare that to the H plus M minus, which is the dark blue line, the GFR here is slightly better at 35. And then you have a dotted orange line where it's the H minus M minus, where the GFR is around 40 at the time of biopsy. Over a median follow-up of the next several months, you can see that GFR does improve in all three groups. But the key point is that the H plus M minus group is showing improved GFR without any specific rejection therapy. To us, what this suggests is that the inflammation seen in this group is actually a response to non-specific wounding as opposed to cognate alloimmune recognition. When you look at graft outcomes, you see similar patterns where H plus M plus has a much worse graft survival compared to H plus M minus, which is very similar to those without rejection. So once again, the message seems to be from this that the H plus M minus group either represents very mild rejection, which never needed to be treated, or no rejection whatsoever. And the molecular tools were able to help us delineate that in the study. We've looked at some other tools from our cohort, and what we did in this particular analysis was to divide our patients into two groups: those who had stable or improved kidney function after the initial biopsy versus those who either lost their transplant or had a loss of GFR of 30% or more at 6 months post-biopsy. And around 70% of this cohort met that definition. When we looked at the predictors of who does what based on histology, you can see that those who had more IFTA on histology did worse, which is not surprising at all. But there are no other differences which are clearly seen in this group. But when you look at the molecular analyses, you can see there's a pretty profound difference between these two groups with regards to global disturbance or inflammation, acute kidney injury, and atrophy fibrosis. When we looked at the multivariate model to look at these predictors, AKI score was the strongest predictor of outcomes in the study. And this has once again been reported already in the ABMR cohort by Dr. Halloran, and this data includes our own center data. What you can see on this slide is that the IRATs, which is injury repair associated transcripts or AKI transcripts, are by far and ahead the most important transcripts to predict outcomes in the ABMR patients. The point of this paper is that one needs to consider severe AKI in the algorithm of outcomes. And once again, the impact of this is with regards to management approaches as to how aggressive or how conservative one needs to be when managing a patient. We've used MMDx in other cohorts with regards to response to therapies, for example, chronic active antibody-mediated rejection. We published a clinical trial where we used Belatacept for chronic active ABMR, and the protocol is listed here. What we showed was that patients who got converted to Belatacept had improvement in stabilization of kidney function over time, where you can see in the left cartoon, their kidney function is rapidly worsening over time till time 0 when they get converted, and then over time, the GFR trend stabilizes. When compared to a controlled matched cohort from the Paris transplant group, our group showed improvement in GFR over time compared to the controls, where GFR continues to worsen over time. The key point, though, for this audience for today is that patients in this group showed improvement in molecular rejection on surveillance biopsies done 6 months after the initial conversion. And you can see this improvement on all of these scores, including ABMR, molecular glomerulitis, and molecular periturbal capillaritis. No such difference was seen on histology with regards to BTC and G histologic scores. An editorial which accompanied this paper in Transplantation discussed and suggested that molecular profiling has the potential to identify changes in inflammation and injury before it is visible by conventional light microscopic examination of renal transplant biopsy. And the authors further said, it is our belief that incorporation of molecular profiling in trials such as these is of vital importance. And indeed, that's already happened. So if you look at this new paper from Dr. Bomik from Vienna, they looked at the role of interleukin-6 antibody clazakizumab for late antibody rejection. They randomized 20 patients into placebo versus claza, and they looked at the GFR trends as well as histologic and molecular changes of rejection over time. What they found in this trial was that the GFR slope of patients who got clazakizumab seems to slow down with regards to worsening compared to placebo, where it continues to worsen over time. And you can see the trend in this graph with the black line for placebo and the red line for clazakizumab. When you look at the impact of this on molecular markers of rejection as well as histologic markers, you can see that DSA goes down, and to break it down, the transparent white bars are the patients who got claza, or the striped bars on further follow-up up till 1 year, and the dark red bars are the patients who were in placebo group. I want to just highlight this one point to you, which is, did not show up, which is the panel B, where ABMR molecular scores are significantly lower compared to the placebo group on surveillance biopsies, suggesting that clazakizumab resulted in less molecular inflammation over time. And this has now led to a much bigger trial, which is being done right now across many centers across the world. We've looked at other molecular tools. And so in this study, we looked at the comparison of simultaneous assessments of histology, MMDx, as well as blood-based donor-derived cell-free DNA. And the intent of this study was to look at the comparative values of cell-free DNA, MMDx, and histology in making a clinical diagnosis. When we looked at the AUC for histology versus cell-free DNA for rejection, it was found to be 0.75 as compared to MMDx, but it's slightly better at 0.8, indicating that MMDx aligned better with cell-free DNA compared to traditional histology in the study. When we dig deeper into this data and look at the traditional cutoff of 1%, which is used to diagnose rejection based upon published studies for cell-free DNA, what you see on the left is histologic rejection being no with the black dots, and MMDx rejection being no with the black dots on the right. You can see that for the biopsies where cell-free DNA is more than 1%, there are a lot more non-rejections by histology compared to MMDx. And the question is, were they false negatives? When we look at who were these patients who were false negative, most of these turn out to have antibody rejection. So the theme of MMDx picking up early ABMR versus histology is continued in the cell-free DNA analysis also. Similar data was just published in the last couple months from the Trifecta study, where again, in a multi-center cohort from Canada, the US, and Europe, when cell-free DNA was calibrated to diagnoses, there was a strong correlation for both ABMR as well as TCMR, although with TCMR was slightly weaker. Nevertheless, the point remains that the calibration and the alignment with MMDx was slightly better than that for histology with cell-free DNA in this study also, similar to the one I just showed you a moment ago. Another interesting study, another interesting analysis from our cohort is with regards to molecular acute kidney injury. And what you see here is that for all biopsies, be it with or without rejection, the acute kidney injury score from molecular analyses aligns and is strongly correlated with cell-free DNA. What to us this means is that molecular AKI is again consistent with injury to the cell-free DNA also. Essentially, they're both measuring the same thing, which is injury to the kidney. And the hope is that when we can use these tools to determine prognoses, they could be complementary to each other also in the future. So what's next? The biggest things that we need to do now is to look at incorporating MMDx analysis into hard outcomes. We're doing that right now with our antibody-mediated rejection cohort. Can we start talking about incorporating this into clinical trial measurements? Then finally, eventually, maybe therapeutic discovery. So one example of why molecular gene expression may be a powerful discovery platform is this paper, which was again published late last year, because it can allow us to reanalyze previous data, since the gene sets collected are pretty tremendous in regards to volume. So if you look at this analysis, when we re-examined DSA positive biopsies, it was found that some of these actually had mild rejection-like changes, although initially neither histology or MMDx called it rejection. And this corroborates what we actually know about DSA, which is that DSA positive patients do worse than DSA negative patients over time. I think with that, I'm going to end. I'll welcome any questions you may have. Thank you for your attention.
Thank you so much for this amazing presentation, as always. Thank you all again so much for joining us.
Thank you.